Bismillahirrahmanirrahim. Today we are going to study diabetes in pregnancy, management from the preconception and to the postnatal period, and this is NICE guideline and it was published in 2015. So first of all, we'll start with the preconception planning and care. First of all, information given to the woman is very important about the outcomes and the risks associated with diabetes mellitus. Your aim should be empower the woman with diabetes to have a positive experience of pregnancy and childbirth by providing her information, advice, and support that will help to reduce the risks of adverse pregnancy outcomes for both the mother and the baby. Then explain to the woman with diabetes who want to become pregnant the information about a good blood glucose control level, and that this good blood glucose control will help in the reduction of miscarriages, the congenital malformations, the incidence of intrauterine deaths or stillbirth, and then the neonatal death. Explain to the women who are diabetic and want to become pregnant that how diabetes affect pregnancy and how pregnancy affect diabetes, and for this it is very important to provide them the information of diet, body weight, and exercise, the risk of hypoglycemia and impaired awareness of hypoglycemia during pregnancy, how nausea and vomiting will affect the blood glucose control in pregnancy, the increased risk of having a large for gestational age baby, which will increase the incidence of birth trauma, induction of labor, and obviously cesarean sections, the need for assessment of diabetic retinopathy before and during pregnancy, and the need for assessment of diabetic nephropathy only before pregnancy, right? So it is important for the assessment of diabetic nephropathy is that you check a urinary and you check for the albumin urea, plus you carry out the renal function test. So if her creatinine is more than or equal to 120 micromole per liter, if her estimated GFR values are like less than 45, and if her ACR is more than 30 milligram per millimole, then you have to refer this patient to a nephrologist and advise them not to discontinue contraception before that, right? Okay. After that, tell them the importance of maternal blood glucose control during labor and birth and early feeding of the baby in order to reduce the risk of neonatal hypoglycemia. Also tell them the possibility of temporary health problems in the baby during the neonatal period, which may require admission to the neonatal unit, and the risk of the baby developing obesity and diabetes in later life. So this is all the information that you provide to a diabetic mother. Explain her the role of contraception. Advise any woman who is diabetic that she should avoid an unplanned pregnancy because this is associated with a lot of complications and risks associated with it. The choice of contraception depends upon her own preferences as well as the any other associated risk if she has. Advise women who is diabetic and wants to use contraception is that if there is no other contraindication for the use of oral contraceptive pills, she can use it. The risks of diabetes or the complications associated with diabetes actually increases with the increasing duration of diabetes. What about monitoring of the HbA1c levels? Well, these women should become pregnant only if their HbA1c levels allow. The target HbA1c levels are, there is basically an individualized target level for glucose. Any woman who wants to become pregnant, right, in the preconception period, you have to provide her information that she should aim for a fasting blood glucose level the same as for a patient with a type 1 diabetes are offered. That is a fasting blood glucose level of 5 to 7 millimole per liter and a random blood glucose level of 4 to 7 millimole per liter before eating at other times of the day. The target HbA1c levels before conception should be less than 48 millimole per liter, that is 6.5%, and it will cause a reduction in the congenital malformations. And you should strongly advise the woman to avoid pregnancy if there is an HbA1c level of more than 86 millimole per liter, which makes it about 10%, right? Okay, then the blood glucose targets, blood glucose monitoring, and the medicines for treating diabetes and medicines for complications of diabetes will need to be reviewed before as well as during pregnancy, and that extra time and effort is needed to manage diabetes during pregnancy, and she will have frequent contact with the healthcare professionals and give women with diabetes who want to become pregnant that there are local arrangements for support, and also provide them with emergency contact numbers. Okay. The advice regarding diet, there should be an individualized dietary advice for these women. Any woman who is having a BMI of more than 27 kg per meter square should be advised how to lose weight in line with the NICE guidelines on obesity. And any woman who is diabetic and want to become pregnant should use folic acid 5 milligram daily up till 12 weeks to reduce the incidence of neural tube defects. Okay, then advise these women to monitor the blood glucose levels and ketones. That is, the HbA1c levels should be checked on a monthly basis in a diabetic mother in the preconception period. Number second, she should use a glucometer for the self-monitoring of blood glucose levels. And if she needs an intensification of her treatment of anti-diabetic medications, then the frequency of self-monitoring should be increased. That is, increasing the fasting blood glucose levels and then a mixture of pre and post meal levels. Any woman who is having type 1 diabetes and who is planning to become pregnant, blood ketone testing strips and a meter, and advise them to test for ketonemia if they become hyperglycemic or unwell. Okay, so now we have the safety of medicines during diabetes, right, for diabetes. And then we have the safety of medicines for the complications associated with diabetes. So first of all, the safety of medicines for diabetes, advise the woman, right, to use metformin as an adjunct or alternative to insulin in the preconception period or during pregnancy when the likely benefits from improved blood glucose control outweigh the potential to harm, right? And all other blood glucose lowering agents should be discontinued in this period. Be aware that data from clinical trials and other resources do not suggest that the rapid-acting insulin analogs, that is Aspart and Lispro, they adversely affect the pregnancy or health of the baby or the unborn baby. And use isophene insulin, also known as NPH insulin, as the first choice for long-acting insulin during pregnancy. Consider continuing treatment with long-acting insulin analogs, Detamir and Glargine, in women with diabetes who have established good blood glucose control before pregnancy. Okay, then there is a concern about the safety of medicines for complications in pregnancy. So any woman who is using ACEIs and ARBs, they should be discontinued, and any alternative medications should be used. And the use of statins should also be discontinued before pregnancy or as soon as the pregnancy is confirmed.